This is Damian McNamara with Elsevier Global Medical News, and I'm at the Perspectives in Rheumatic Diseases meeting with Dr. Christopher Ritzland, who's the Director of Clinical Immunology at the University of Rochester in New York. Thank you for being with us, Dr. Ritzland.
Thank you. It's a pleasure to be here, Damian.
Now, one of the things that you're going to talk about tomorrow at this meeting is the interface between rheumatologists and dermatologists and how it's important to have that kind of coordinated care. Can you tell me a little bit more about that?
Of course. So psoriatic arthritis is a disease that involves not only the joints but also the skin, as well as these patients have a higher prevalence of metabolic conditions such as diabetes and metabolic syndrome, and they also have an increased risk for cardiovascular disease. Also, these individuals often do not see primary care doctors because they're younger and they're seeing a dermatologist and a rheumatologist, so it's incumbent upon us to manage their care globally. In order to do that, we need to work together. So not only in terms of treating their joint inflammation, but also helping to manage their skin conditions and their overall health. And to do that requires close collaboration between dermatology and rheumatology. So for example, it's not uncommon for us to see patients in January in upstate New York who have psoriatic arthritis whose joints are doing fine but tend to have a flare of their skin disease. So the treatments for that skin disease can range anywhere from light therapy to topicals to adding methotrexate or cyclosporin, or actually increasing the dose of an anti-TNF, for example, if they're on that. But it's really very individualized, and it requires close discussions between rheumatology and dermatology to really reach therapies, choose therapies that are most effective for the individual patient.
Okay, that sounds great. Can you give me an example of a particular patient, perhaps, without violating any sort of HIPAA regulations, that did well with this coordinated care approach?
Yes, I can describe a patient who had psoriatic arthritis, who had very much similar to what I just described, a very severe flare of psoriasis, who had gone to a dermatologist outside the area, who stopped their anti-TNF medication and put them on a drug called eculizumab, which is an agent that blocks T cells. Regrettably, that drug does not do well for the arthritis. So this individual ended up having a severe flare of psoriatic arthritis to the point that they could not walk. Their psoriasis did somewhat better, and they ended up at our psoriasis center, which we have in Rochester, where we have close collaboration. We work together with dermatology, and we were able to develop and put that patient on treatments that were able to address both the skin and the joint, and the patient did ultimately do very well.
What are the unanswered questions in psoriatic arthritis? Like, what still needs to be addressed?
I think the major question is, what are the underlying mechanisms that link the joint and skin disease? And the skin and joint disease, because in most patients the skin disease proceeds by up to 10 years. And I think that with the revelation of some of the basic immune mechanisms, we're getting closer to understanding that important links, but still we have a lot of work to do. I think the other important area that we're very interested in is trying to identify those patients with psoriasis who are at risk for arthritis, so that we can do early intervention to perhaps even prevent the onset of arthritis in the 25% of patients with psoriasis who are destined to get inflammatory arthritis.
Okay, thank you very much for being with us. This has been Damian McNamara with Elsevier Global Medical News.